Bismillah Rahman Rahim. Today we will have case quiz number 69. Case data: 31 years old female complaining of 2-year history of arthritis of the hands, of wrist, ankle associated with early morning stiffness. So 2-year history of arthritis of hands, wrists and ankles with morning stiffness. The past medical history included mild asthma and depression. She smoked 15 cigarettes a day. There was no family history of arthritis or autoimmune diseases. On examination, we found a swelling of the small joints of the hands and wrist and wasting of the intrinsic muscles and reduced grip strength. Small nodule at the left elbow. Investigations showed chest X-ray was unremarkable. Hand X-ray suggested carpal crowding and periarticular osteopenia with a small erosion at the distal end of the proximal phalanx. Regarding management, the diagnosis of rheumatoid arthritis was made, and she was treated with intramuscular steroid as a bridge therapy with methotrexate and hydroxychloroquine. The following year, she presented with shortness of breath on exertion. Her methotrexate was stopped, but the shortness of breath progressed and she developed orthopnea. So dyspnea and orthopnea. On admission, she was found to be tachycardic and hypertensive. The chest X-ray for the second time demonstrated increase in the cardiac shadow. An echocardiogram demonstrated a pericardial effusion as well as severely dilated left atrium, mitral regurgitation and reduced ejection fraction at only 49%. MRI gadolinium cardiac scan showed left ventricular hypertrophy, dilated left atrium, pericardial effusion, moderate mitral regurgitation, and thrombus in the left apex. It also demonstrated endomyocardial inflammation or fibrosis. This is the chest X-ray showing increased cardiac shadow. And this is the echocardiogram showing left ventricular hypertrophy, pericardial effusion, thrombus in the apex, endomyocardial enhancement demonstrating inflammation or fibrosis, and endomyocardial enhancement pattern. So it is a complication or possible complication of rheumatoid arthritis maybe. So what are the causes of shortness of breath in RA in rheumatoid arthritis patient? Here we will need the answer to be two phases of the answer, generally speaking and especially for this special case. So we have no single answer like the previous quizzes, but they are differential diagnosis. The causes of shortness of breath in rheumatoid arthritis include pulmonary causes such as non-specific interstitial pneumonia (NSIP), idiosyncratic allergic alveolitis associated with drugs such as methotrexate, leflunomide or citalopram, pulmonary fibrosis, pleural effusion, pulmonary hypertension. These are the pulmonary causes of shortness of breath in RA. Other causes include cardiac, such as pericarditis, pericardial effusion, or cardiac amyloidosis. And finally, hematological causes such as anemia may be the cause. So, as we see, there are multiple differential diagnosis for this case? This was the generally speaking differential diagnosis for the shortness of breath generally in rheumatoid arthritis. But in such a specific case, the chest X-ray demonstrates significant increase in the cardiac shadow or cardiac size. The differential diagnosis of this include left ventricular failure, pericardial effusion, left ventricular hypertrophy, dilated cardiomyopathy, or hypertrophic cardiomyopathy. So, what is the differential diagnosis for endomyocardial inflammation or fibrosis? This includes cardiac amyloidosis, hypertensive heart disease, ischemic heart disease, rare side effects of the DMARD such as methotrexate, eosinophilic myocarditis. Other causes of myocarditis might include infections such as viral adenovirus, parvovirus, human herpes virus, and HIV virus, or connective tissue disease such as SLE or scleroderma, or finally sarcoidosis. The pattern of endomyocardial enhancement seen in echocardiography for this specific case was considered to be typical for eosinophilic myocarditis rather than amyloidosis. There is a documented association between rheumatoid arthritis and eosinophilia. This was first described in the 1970s. It was later recognized that there are two patterns of eosinophilia, one related to the disease process itself and the other related to the therapy, such as gold or penicillamine, which are both obsolete now. The extra-articular features of rheumatoid arthritis, such as pericarditis, pulmonary fibrosis, and rheumatoid nodule, are more common in patients with eosinophilia. The relationship between tissue eosinophilia and rheumatoid arthritis is less well known. There are documented cases of rheumatoid arthritis with eosinophilic pneumonia, eosinophilic enteritis, and even eosinophilic meningoencephalitis, where no other causes for eosinophilia is found. So eosinophilia here is caused surely by rheumatoid arthritis itself. The explanation of eosinophilic carditis here: we know that eosinophils are harmful to the myocardium. Chronic eosinophilia has been associated with endomyocardial fibrosis and even myocardial damage. This tissue injury is a direct result of degranulation of toxic eosinophilic granule proteins. Other causes of eosinophilic myocarditis may include idiopathic hypereosinophilic syndrome, parasites, rejected heart transplant, drug reaction, or vasculitis such as Churg-Strauss syndrome. These are other causes of eosinophilia rather than rheumatoid arthritis. We said a few minutes ago that rheumatoid arthritis may be associated per se with eosinophilia, but it may be associated with other conditions which are more commonly associated with eosinophilia, such as idiopathic hypereosinophilic syndrome, parasites, rejected heart transplant, drug reactions, or vasculitis. Regarding the outcome of this case, the patient was successfully immunosuppressed with infliximab, and this normalized her eosinophilic count. She showed improvement of her cardiac function, including reduction of the left ventricular mass, rise in ejection fraction from 46% to 74%, and the reduction of the endomyocardial enhancement demonstrated previously in the previous imaging studies. And so the patient improved markedly on immunosuppression with infliximab. And finally, thank you very much for your attendance, and we will meet you tomorrow with case quiz number 70. Wassalamu alaikum wa rahmatullahi wa barakatuh.